Hi, in this section we want to talk about the acute abdomen, and I want to relate the symptoms and signs you're going to be eliciting from your patients to the anatomy which we've seen in the dissecting room. First of all, let's draw a diagram of the abdomen and the back as you would do when you're making your careful medical notes recording your examination findings. You're always cramping my style, what little style I have. Now move out the way. So, an abdomen. And a back. With scapulae and pelvis. Make them big, a whole sheet of A4 for each one, so that we can then annotate it. Alternatively, you could download some really elegant diagrams Charlie's done from this section of the blackboard. So hopefully you've got your diagrams either hand drawn or Charlie's, so you're all ready to annotate those. So some of you will notice on Charlie's super diagram there's these different quadrants have been marked out. Let's just briefly revise those. Starting on the right hand side, we've got the right hypochondrium, called the hypochondrium because it's underneath the costal cartilages. Centrally in the upper part of the abdomen, the epigastrium, because it's around the stomach. Then the left hypochondrium. Around the tummy button, we've got the umbilical region. Keeping going down on the left hand side, the left lumbar region. People often call it the loin, and you often find patients complaining about loin pain. Further down, we've got the left iliac fossa, because it's an indentation around the iliac bone. Centrally at the bottom, we've got the hypogastric region, because it's below the stomach. Also called the suprapubic region, because it's just above the pubic bone. Then we've got the right iliac fossa, and lastly, the right lumbar region or loin. On another sheet of paper, write down some headings, the organ and the disease, the position of that organ, making particular note whether it's intraperitoneal or retroperitoneal, and then the site of the pain you'd feel with the disease process in that organ. Once you've got that, pause the video and annotate your diagrams and fill out the list. One of the problems about doing this in theatre is you get video bombed by idiots like this. So my general surgical colleagues pointed out that as a plastic surgeon, I forgot that the duodenum is retroperitoneal and I need to annotate my back diagram accordingly. Sorry about that, but good job we got to check it. So here's our fully annotated slide, and hopefully your slides will look very similar to this, but probably with neater writing. So whilst we're on the duodenum, let's talk about that. This can cause pain and symptoms from a duodenal ulcer, which can perforate. But why have I labelled the difference between intra-abdominal and retroperitoneal? Well, it's because of the symptoms. Those structures in the retroperitoneum, such as the duodenum, pancreas, aorta and kidneys, will cause symptoms in the back. It's crucial to understand that, so we don't miss an acute abdomen in a patient presenting with back pain. It's also crucial when you're accepting patients from GPs. You don't want to be that orthopaedic FY1 stuck in an orthopaedic hospital accepting a patient with a potential ruptured aortic aneurysm when the GP thinks it's discitis. The reason for them to be hypotensive, tachycardic and white as a sheet is unlikely due to be back pain, more likely because of the aortic aneurysm leading into the retroperitoneal space. When an aorta ruptures, it doesn't bleed into the peritoneum, that hematoma builds up in the retroperitoneal space. So there may be no guarding or signs of peritonism at all, just back pain. The pancreas also sits in the retroperitoneum, and this is extremely painful if it becomes inflamed and the patient has pancreatitis. If they develop gardening and peritonism, that's a sign that there's been a build-up of peritoneal fluid and the disease has progressed.
So let's go to the right hypochondrium. Here we've got the liver and the gallbladder, and any disease process causing inflammation of these will give pain in this region, such as cholangitis or cholecystitis. Remember, we've also got the liver attached to the diaphragm via the bare area. The innervation of the diaphragm is C345, keeping it alive, so therefore stimulation and inflammation of the diaphragm can cause shoulder tip pain. Remember, C5 is also part of the upper part of the brachial plexus. In this region we've also got the hepatic flexure of the colon, so colonic diseases can also give you right upper quadrant or right hypogastric pain. So let's go to the epigastrium. Here we've got the stomach, so any stomach ulcers or perforated stomach ulcer will give you epigastric pain. Fortunately, we see this far less commonly due to the introduction of antacids and proton pump inhibitors. Don't forget the duodenum and the pancreas also sit in this region, but as we've said, they present more with back pain, and it's not until the advanced disease processes may you start seeing pain anteriorly. Moving across to the left hypochondrium, essentially here we've got the spleen. Not many primary diseases cause inflammation of the spleen, however trauma can cause a rupture or a partial rupture of the spleen, and you get significant bleeding into the abdomen as it's intraperitoneal. We've also got the splenic flexure of the colon, so again colonic diseases can cause pain in the left upper quadrant. Also remember, it's still got this attachment to the diaphragm, so problems sitting just underneath the left hemidiaphragm can cause left shoulder tip pain via C345. So going to the left lumbar region, we've got the kidney, and you've got the ureter descending down into the pelvis from there, and certainly renal colic with the stones causing partial blockage and the peristaltic ways of the ureters working against it can be extremely painful. If it progresses and you get an infection in the kidney with pyelonephritis, again you've got to feel that pain in the lumbar region round towards the back. We've also got the descending colon, so constipation or large bowel obstruction can cause pain in this region too. So shifting down to left iliac fossa, essentially we've got the sigmoid colon sitting here, and any inflammation of the sigmoid colon stimulating the parietal peritoneum can cause pain in the left iliac fossa. The classic one is diverticulitis, which can progress to forming small abscesses or even perforations. Don't forget we've also got the pelvic organs such as the ovaries in the lady in this region. So moving to the lower abdomen in the hypogastrium or suprapubic region, in the male we've just got the bladder. Problems with the prostate tend to feel pain in the perineum because it's extraperitoneal, but in the woman we have the ovaries, uterus and fallopian tubes, and these are intraperitoneal structures, so you can get lower abdominal pain from any disease process affecting those, such as endometriosis, ruptured ectopic pregnancies or cysts. So let's shift around the corner to the right iliac fossa. Here, this classically pain due to appendicitis. But remember, appendicitis pain usually starts centrally and shifts to the right iliac fossa. This can be explained by the innervation of the visceral and parietal peritoneum. Initially, the inflammation will just be in the appendix itself, covered by the visceral peritoneum. This has afferent fibres of the sympathetic nervous system, and the brain can't localise where that inflammation or pain is coming from. As the disease progresses, the appendix may start causing inflammation of the parietal peritoneum in the right iliac fossa. This can then be localised by the brain as it's got its somatic innervation, and the pain will be felt in the right iliac fossa. So this does various things. First of all, it tells us the diagnosis that the problem's in the right iliac fossa and it's shifted to it. It also tells us that our disease has progressed from just within the appendix to outside of the appendix and the surrounding parietal peritoneum. So it also tells us that our patient is going to be sicker, and they've got a worse disease process. So understanding that anatomy gives you quite a lot of information. So if we go up to the right lumbar region, we've got the ascending colon and kidneys and ureter, so a similar symptomatology compared to the left lumbar region. However, we've got the ascending colon. Remember, the ascending colon has more fluid contents than the descending colon, so you don't tend to get so much pain from constipation on this side. So finally, let's go on to the umbilical region. Central colic abdominal pain is usually associated with small bowel obstruction. The commonest cause for this is adhesions from previous surgery, but it can be associated with tumour causing blockage or kinking of the small bowel. But let's not forget the arteriopath, who presents with central abdominal pain and can be really ill. They may have atherosclerosis of their superior mesenteric artery and have small bowel ischemia, a really difficult problem to solve and has a poor survival rate. So hopefully that's been a good revision of the layout of the organs of the abdomen, and you can relate where a patient's feeling pain to an organ and a disease process within that organ. Remember the difference between intraperitoneal structures and extraperitoneal structures and their symptomatology. Then you won't get caught out with a patient with back pain missing an acute abdomen.
For those of you who like lists, we've produced a list. I'm sorry it's gone on to 2 sides. Well, I really hope that's been a useful exercise for you, and you've got a confident way of going through the anatomy of the abdomen, and you can be confident when you're marking those acute surgical admissions about what symptoms are causing what problems in what organ, so you can tailor your investigations along the right lines. If the worst comes to the worst, you've actually got an aid memoir you can stick on the back of the toilet door, so when you're taking a brief break, you can do a quick amount of revision. I hope it's going to give you that confidence on your surgical firms. The general surgeons are great fun to work with. In fact, we're doing a pelvic reconstruction I've got to get back to now. So take care and best of luck with your surgical house jobs.